All right, let's go ahead and get started. I want to respect everyone's time this morning. Good morning. I am Heather Logan, and I work at CU Medicine in the Office of Value-Based Performance. And I am the chair of the Aurora Health Alliance Board of Directors and am very enthusiastically passionate about access to specialty care. It's something that I think we continue to struggle with as we try to create better access in our healthcare world, and it's something that we have continued to problem solve and try to build solutions around for quite some time within the Aurora Health Alliance. And so we have this great work group where we just share information for those of you that are new here today, and try to collaborate and find ways where we can perhaps share data and partner more on creating better access. I also co-chair with Molly Markert from Colorado Access and Rich McLean, who is also an Aurora Health Alliance board member. So our topic today is to talk a little bit about access to specialty care, specifically for the Medicaid population in a few different areas. And one area that really has gotten a lot of attention, not just from patients self-reporting, but also from healthcare policy and finance, is access to dermatology. So before we dive into more discussion about dermatology, I wanted to share with you a little bit of the background on a data deep dive that took place between the CU School of Medicine, as well as HCPF, Healthcare Policy and Finance, to further understand what areas of specialty care might need further attention. Sometimes I feel like specialty care access is boiling the ocean. There's a lot that needs to happen. So if we can kind of refine down our efforts and focus on a few areas more diligently and more strategically, we're able to move the needle. So I'd like to share with you a little bit of the history. The CU School of Medicine worked in partnership with HCPF to jointly create a specialty care prioritization list. This list was developed in about 2018 into 2019. A lot of data was pulled, a lot of talk, not just with looking at claims data, but referring providers and care managers to better understand what areas of specialty care are sometimes more challenging for Medicaid recipients to gain access to. So both organizations did surveying and data sharing. Out of that analysis in 2018 and 2019, a specialty care prioritization list was developed. And the 8 areas that were identified were cardiology, urology, neurology, dermatology, endocrinology, orthopedics, gastroenterology, I always butcher that one, sorry, and rheumatology. So those 8 areas really showed where things start to get bottlenecked. When Medicaid patients are trying to access those key areas, there tends to be a harder time with access. So how can we creatively try to find ways for patients to better access those 8 areas? So there was an additional further analysis that was done to try to whittle it down a little bit further and look at the 3 areas where we might be able to partner further with healthcare policy and finance. So more data was examined, more conversations occurred last year in 2020. And the 3 areas that are the priority for the CU School of Medicine and Healthcare Policy and Finance specific to the Medicaid population is urology, dermatology, and rheumatology. So what happens next? So looking at these 3 areas, right now, a lot of stakeholder interviews and evaluation is occurring. So there's conversations happening with referring providers and their care teams on what does it look like when you want to refer to urology? How do you refer to dermatology? What barriers do you encounter with rheumatology? We're also doing a lot of conversations with specialty care providers and their care teams to understand on the flip side, what are they seeing when individuals get referred to them? What would they like to see in those referrals? And how can we streamline it better for patients? Lastly, there's conversations happening directly with patients. And these are individuals that are trying to access care in those three areas, trying to access care for urology, dermatology, and rheumatology. So in this next year, the organizations will partner to undergo a root cause analysis and develop strategic goals to address potential barriers to care and process improvement opportunities. So this is where it gets a little bit more of rolling up the sleeves and diving in to further understand where we might be able to find some solutions. So we are identifying barriers and potential solutions to accessing specialty care in those areas that I mentioned. Really trying to understand the referral process for each of those areas, program evaluation and quality improvement opportunities that we can really follow and see where we might be able to streamline efforts, and continued adoption and further interoperability for EConsult activity. There's already been some good data released, and I know the Aurora Health Alliance did a great job of putting together a EConsult webinar series to talk about how EConsults can really help with access. And so how can we empower primary care providers to treat some conditions in a primary care setting and with the guidance of a specialist, as opposed to referring them all into specialty care. So the root cause analysis is starting next month with a deep dive between the CU School of Medicine as well as HCPF. Some potential solutions is really trying to increase access through various mechanisms. I think, having a background, I worked at a FQHC for 10 years, and just seeing what patients went through and the struggles they encountered with trying to access specialty care. It's not a one-size-fits-all solution, and I think it looks different for each different specialty care area. It's going to look different for dermatology compared to urology, compared to rheumatology. And it's not a solution of just, let's hire more specialty care providers. That can be helpful in creating better access, but there's also other solutions that we can use with technology, patient education and awareness, and working closely with primary care providers and specialty care providers in setting up good systems for referrals. There's also potential with echoes, and that's really providing that provider education on how to treat certain conditions more in a primary care setting. So urology is going to be doing a series this year in things that can be treated in a primary care setting, and then how we can really work together to prevent emergency room utilization for some urologic conditions. There's also, I think we've learned this last year with COVID, such an opportunity for telehealth and how that can provide additional access support. So one thing we're looking at CU Medicine is what specialty care areas lend themselves better to telehealth. Not all of them do. Ortho, you really need to get your hands on that patient, and it's just a little bit of a different model, where with dermatology, for example, we're starting to really advance in how pictures are taken and how they're scanned and what can be done more remotely. Another area of interest is care transitions, and seeing that we have a very large pediatric population who are recipients, Medicaid recipients, and they need to access adult care. And so how do we streamline our pediatric patients from children's into adult care and ensure that they get access to specialty care as well? So we're doing a deeper dive into what that volume looks like and how we can make that transition as smooth as possible. So let's talk a little bit about dermatology. One thing that has become very clear is that people with skin of color face unique dermatologic concerns. Skin health is critical to whole patient wellness, and healthcare systems must align their clinical and operational goals to create optimal skin health outcomes. So we know that skin disease can affect anyone, but it really might not affect everyone in the same way. And that's very true for individuals who have skins of color. So knowing that skin conditions are colorblind, they occur in patients of every skin tone. Certain conditions can affect patients with skins of color more frequently and more severe. So hypopigmentation, hyperpigmentation, certain forms of skin cancer, chronic wounds that have healed in a variety of different ways, rashes, and eczema. And one thing that we're starting to see a little bit more of specific to the refugee population coming into Colorado are their skins of color who really aren't prepared for the Colorado weather. So how can we ensure that new refugees coming into Colorado get support through dermatology as well? The National Library of Medicine did a clinical trial, and they looked at dermatology access limitations in hotspots where there's Medicaid uninsured population is higher. So we've heard that term before, hotspotting, and that's more where we've seen it with ER utilization, having hotspots, or inpatient or costs. And it's no surprise that the same zip codes that have the highest emergency room use in the state of Colorado are also a hotspot for specialty care access. And that's the zip codes that are really surrounding the Anschutz Medical Campus, 80010, 11, and 12. And so that's for pediatric and adult care. We're starting to see these hotspots of an increased need for access to specialty care. And a lot of that is really just based on the demographics. We have a higher Medicaid population and a very high uninsured population in these zip codes. So one thing that we're focusing on is really the prevention piece of dermatology. Skin health is not always prioritized by patients or primary care providers. And there is a need for further dialogue between primary care and patients when it comes to skin care prevention. Some of the conversations we've had with patients really is they might have other crises that are happening either personally or medically, where skin care starts to fall lower on their priority list. They're really trying to manage their chronic condition, whether it's their diabetes or their asthma. And sometimes their visit with their PCP doesn't allow time to talk about their skin. And unfortunately, what happens is by the time patients do seek care, the skin condition can be advanced. And so it's waiting, oh, there's that mole that I've been having trouble with. It falls down on that priority list, falls down, until what we see a lot of times with dermatology costs is they're more in the catastrophic range because people have waited so long to seek care. So what can we do to help primary care providers in our community work with patients to better identify skin care needs? A big part of that is through the wellness visit opportunity. And that's something that's a big focus under the Accountable Care Collaborative, which oversees care for Medicaid individuals accessing primary care. There's a key performance indicator that specifically looks at increasing wellness visits. And most electronic health records in the primary care setting have a section in a wellness visit focused on skin screening. What we're starting to see more is that that's not always happening in a wellness visit. And so if a skin screening doesn't take place in a preventative manner, it's not always going to be a situation where patients are going to specifically go in and see primary care specifically for their skin. So the wellness visit in primary care is a perfect opportunity for providers to really do an examination of skin and make an appropriate referral into dermatology. Another area is creating better awareness and education around the importance of skincare and really targeting certain populations who might not normally see that as something that they need to think about. And really highlighting that we now have a dermatology clinic specifically targeted at serving Medicaid individuals right in the hub, right in the hotspot zip codes where we need better access to specialty care. So I do have some partners that are in our meeting today. They're going to talk a little bit about that new dermatology clinic. But I'll go ahead and see if there's any questions for me.
Heather, what was the most surprising part, especially with dermatology, with this data that you noticed?
You know, I've talked to a lot of dermatologists in Colorado and then some at a national level. And what really surprised me is that many of them reported that there wasn't a focus in textbooks or when they were in school focused on skins of color. Many of them don't remember ever covering that or having it a part of their medical school experience. And I did do a deeper dive into looking at some of the textbooks that are used specific to dermatology. And many of them don't have a focus on skins of color. And so I think that's a gap and something that needs to change. And something that we can kind of create more awareness and education at a local level. But I also think it's something that we need to change on a national level.
Heather, that's been just a great presentation and a great overview. Looking forward to hearing from the Aurora dermatology clinic. And then later on today, before we end anyway, we'll get an update on specifically what's happening within Aurora, within primary care with Aurora and specialty care. So looking forward to that too.
Yeah, it all starts to align, right, Rich? There's a lot of efforts happening, and I think this creates a great venue and an opportunity for us to come together and talk about what's happening with access to specialty care. And if we can specifically, look at certain areas and collectively work towards creating better access, I think we'll move the needle quicker and sooner. So yeah, really trying to hone in on those 3 areas and follow over time what that looks like for creating better access for patients. Great. Well, I think that if there's no other questions, I'll go ahead and turn it over to the dermatology clinic. And to present, we have Kelly Morin and Taylor Thompson. And if there's anything you need in terms of screen sharing, just let us know. And thank you so much for joining us today.
So my name's Taylor Thompson. I'm one of the nurse practitioners for the CU Dermatology Clinic here in Aurora.
And I'm Kelly. I'm the other nurse practitioner. We are the primary people who see most of the patients who come to our clinic. There are a few other providers who do see patients here as well, but it's more for very specific types of care. Dr. Hai, who is also on this call, he and Dr. Dunick do come in and do patch testing for specific contact allergies. And then we have Dr. Gurney, who does that for pediatric patients. And Dr. Torres comes in and does laser hair removal only for very specific medical conditions such as HS, which is covered by insurance.
So Kelly and I are here Monday through Friday, essentially, and we staff the clinic. So it is important, I think, sometimes for patients to know when they're being referred that they will be seeing a nurse practitioner for their dermatology concerns. Some patients are very specific that they want to see a MD or a doctor, and we don't have doctors who actually staff just regular dermatology appointments here. So we are located in Aurora. We're like right across from the new In-N-Out. So if anybody wants to come hang out, you can go to In-N-Out as well and wait in a very long line. But we're actually located within a Westera Credit Union building. We're on the second floor. We can see patients by referrals. They can be either placed electronically in Epic, or we get them through faxes, and our information is listed below for anybody who doesn't have Epic. And we also don't require that Medicaid patients have a referral. So patients can also self-refer, which is a really great option for people who don't. A lot of patients don't actually have a primary care doctor, and so they just self-refer for their own skin condition concerns. We offer in-person and telehealth appointments. There are a lot of things that telehealth is not really great for dermatology. It's really useful for acne patients, and it's also really useful for follow-up appointments. But we do offer telehealth appointments if patients don't feel comfortable right now with the pandemic coming in to be in person. And we can generally accommodate same week or next week availability. So patients who need to be seen urgently for new rashes or things like that typically can be seen very quickly in our clinic.
So our general clinic mission is to expand care for multiple underserved communities. In particular, I'm going to talk about just a few of the ones that were sort of like highlighted as areas that especially need more care. So for Medicaid patients, we do accept unlimited Medicaid patients. Many clinics put a cap on what percentage of Medicaid they see. And so that does create some really long wait lists for patients and can be a really major barrier to care. We're not planning on capping them. We currently see, whoever wants to be seen here. We also are working on a electrolysis program for the transgender community. Electrolysis is something that we'll talk about a little bit more later on, but it is necessary to prepare a patient before they undergo a gender affirmation surgery. And this is something that is not done in very many places as a covered benefit. We also do take uninsured patients. We take cash pay patients, and if they are able to pay the day of their visit, we give them a highly discounted price for doing that. Something important about that is for patients to understand that it's a little unpredictable. They can't necessarily call and say, how much will this visit cost me? There can be a range of prices, and that's based on the level of billing, how complex the visit is, how many things the patient needs. We can sometimes ballpark things, and for simple types of visits, such as like an acne patient, it's pretty accurate. But if there's potentially a patient that might need multiple skin biopsies or something like that, the price can go up fairly quickly. But we have had more than one patient who has been referred to us directly after getting a biopsy that's been something that's been like a skin cancer that needs to be treated, because we are a more affordable option than for example, like the clinic attached to the university, because there are some costs associated with being at the university, which just being an offsite location, we don't have those. So we are sort of a good option for these types of patients. We also are specially prepared to treat patients with skin of color. As Heather had mentioned before, there are a lot of variations with skin conditions in terms of what you might be seeing. For a patient with skin of color, there are also certain conditions that happen more often in patients of skin of color. And some of the dermatologists who have mentored and trained us have really put a lot of emphasis on these types of patients because we all knew that we'd be here in Aurora and we'd be seeing more of patients with skin of color and needing to be really familiar with what we're looking for and how to really best choose treatments that are going to be helpful for these patients and really address their needs properly. We are also really experienced at this point in working with patients on picking treatments that are going to be affordable for them. Taylor and I spend a lot of time looking for coupons with patients and trying to pick medications that are going to be either covered by Medicaid, or if they don't have insurance, going through and saying like, okay, so this is how much this might cost you. This is how much this might cost you with this coupon. What seems like a good option? What can you afford? What can we do to work with you to make this a treatment that you can actually keep up with? So we're experienced in that.
I think we've also really learned to kind of like what Medicaid requires as far as like failed treatment plans and things like that, and also how to escalate things. So like if there's a patient who just it's not really appropriate for them to wait and trial and fail a medication, then we have the proper chains to escalate that patient's medications and prior auths and get it to the right people to get it approved, to make sure that they get the appropriate care. We've also heard that some barriers to treatments for some patients are geographic. So they live in rural areas. They don't have a they don't have a dermatologist where they live. And so we have, since we've opened, we've served patients from 10 rural or frontier counties. And we've experienced, like Kelly personally has a patient who drives 5 hours to like come to their dermatology appointments. And obviously for those patients, when it's possible, we really encourage them to do follow-ups via telehealth if it's appropriate. That way we can continue their care, follow up and see how things are going, but they don't have to make that long drive if not necessary. So this slide is just a representation of our payer mix. So this is for our clinic here in Aurora, and you can see that the Medicaid patients are the orange patients. And from June to December, whenever we opened in June, we on average have about 35% of our patients are Medicaid. And compared to other private clinics and even the Aurora dermatology clinic at the main campus, we see, obviously more Medicaid patients than any of the surrounding dermatology offices. We accept all insurances. We don't just accept Medicaid insurance. And so you can see that as well. I think too, when we were looking at this, our second highest payer is Medicare compared to Medicaid.
Okay, and this is just a slide of some of the general conditions that we treat. I believe this is from our website. Obviously, patients come in for all kinds of different things that are not going to be on this list. But this is sort of like a representation of some of the common things that people might know that they have, and that's the reason that they are making their appointment and they want to be seen. In particular in Colorado, we really encourage people to do skin cancer screenings. If they're here for, sometimes people will come in and say, I have this one thing that I want you to look at. And we're like, can we please give you a once over? Let's make sure there's nothing hiding. And so we really encourage people when possible to do skin cancer screenings as well as whatever else they may need. We do have a very, very limited number of things, sort of the bottom right, the cosmetic removals. These are different skin conditions that are like little benign tag type lesions that people can find cosmetically bothersome. And we do treat them because it can be really costly for some patients to go to a place to get cosmetic treatments for things. If there is something that is not considered to be harmful, you can't really treat it and then bill it to insurance. So we have some patients who have many, many skin tags like under their arm or something like that. And there's just too many of them. We can't do that and then bill it to insurance. That would be sort of, kicked back as something that wasn't really medically necessary. It's more because it's something that bugs the patient, but not something that's ever going to harm them. And so we do treat these types of lesions sort of in that sort of kind of medical / cosmetic context.
And I think too, even though some of these things sound like very routine, like a skin cancer screening, like Kelly and I have witnessed personally, like patients who have come in who have never been to a dermatologist or they haven't been able to get into a dermatologist somewhere, and they have like horrific skin cancers that, are disfiguring and causing them multiple problems. There are also patients with hidradenitis suppurativa, which is a condition on this list that can be really just like life altering for patients. They're often misdiagnosed by primary care providers. It's not something that I feel like a lot of PCPs really fully understand or know how to treat. And this is like a condition that is just really terrible for patients to have. And when they come in and they're given a diagnosis and they're given a treatment plan, you can really see that it made a difference for that patient, which is really rewarding, I think, for us.
And back with that hidradenitis, this is also a pretty common one that ends up in a lot of ER visits and some like ER misutilization. One of the questions that I always ask our patients on their first visit is, have you had to go to the ER for this? And most of the time they say, oh yeah, I've been to the ER 4 or 5 times. Nobody's known what it was. Now I'm here. So
this is a pretty short list of some skin conditions that are specific to patients of color. So we just wanted to highlight that there are very specific things that we do treat and we're trained in. So hair loss can be obviously for everybody, but there are specific hair losses that you see in patients with skin of color. We see a lot of keloid scars and we do treatments for those. Post-inflammatory hyper or hypopigmentation, vitiligo, and then melasma in our Hispanic or other lighter skin of color patients is also a really common skin condition that we treat.
So electrolysis is a permanent form of hair removal. Laser hair removal is something that is commonly done. It's not really considered to be permanent removal. It's more reduction. And to properly prepare a transgender patient before they undergo gender affirmation surgery, the whole surgical site does need to be completely cleared of hair. That's because it's then utilized to be more internal, and you can't have hair growing in those areas. And so this is a mandatory preoperative procedure that it's not really done in Colorado under insurance. A lot of patients have major barriers to getting this done because they end up having to pay out of pocket and going to like cosmetic salons to have this done. It's really time consuming. Patients have to come in for half an hour to hour long sessions, but they can be doing that every week for several months, and then following up every few weeks for up to a year and a half to really fully clear a surgical site. So it's a really intensive kind of process and can obviously then be really costly. I believe, Taylor, you said it was they were telling you about $5,000 to $7,000. Yeah, so the out-of-pocket cost is really a barrier for a lot of patients. A lot of people can't afford that. And so we are really happy to now be the first clinic that is in Colorado that is offering this through insurance. We are still working on this program. It's brand new, started in January, but we already have 13 patients who are utilizing it, and we're getting more and more referrals all the time. Our goal is to really expand the program, be able to offer this service to many more patients to sort of accelerate their hair removal and prepare people for their gender affirmation surgery. And then just generally to develop a reputation within the LGBTQ community as like a safe space. We would love to see these patients for more than just their electrolysis, for any of their other skincare needs, and do a little bit of outreach to that community as well.
Yeah,
I was just going to note, this is Heather, what a big deal it is that Medicaid is finally covering this. I think a lot of work went in across the state by the LGBTQ community and individuals who really were pushing forward and having transgender surgery and advocacy for this to be a covered benefit under Medicaid. So it's very exciting to see that's finally covered. And I think that your site is seen as a trusted location where individuals can receive this service. And I just see your referrals continuing to grow now that Medicaid is covering that.
Yeah, and I think too, has been a covered service actually for quite a while, I believe, but there just was nowhere for them to go. So because of the way that it's listed in Medicaid, it has to be done by a licensed provider who's licensed with Medicaid. And so a lot of these cosmetic clinics who do electrolysis, there's no way for them to be licensed with Medicaid because they're not MDs, RNs, and Ps, they don't have that connection. And so I've had several patients tell me that, they worked with Medicaid to try and get themselves reimbursed because they went and had this done at a clinic, at the cosmetic center, but they would never able to do that. I've had so many transgender patients just really tell me how incredibly grateful they are that we're now able to offer this. And so, yeah, like Kelly said, I have new consults every week because these patients have waited so long for this service and they just want their gender affirmation surgery. But if anybody is connected with the transgender community, it's just really important to let them know that we only do this for gender affirmation surgery on the genitalia because it's required for that surgical site, but not for the face or the chest. And we're such a small clinic right now, we just don't have the manpower to be able to do that. So as for right now, the only area we can do this for is the genitalia. And then these are just some really great feedback that we've gotten from patients about our location and our clinic. So we continue to hope to have the same feeling from our patients whenever they come and are able to be seen by our clinic. And that's everything.
So it looks like there's one question in the comments about outreach. So really for us, because this is still very new in terms of outreach, it's mainly been with the providers that are referring. We had a meeting yesterday with someone from Denver Health in terms of their gender affirmation team, and then also someone from the university. And sort of discuss their processes in terms of when they get a new patient who is going to be entering sort of the transgender services team and starting to undergo gender reaffirmation surgery versus hormone therapy and all of that kind of thing, sort of discussing their process and letting them know what we're doing here and the sites that we're going to be treating and all of that, just to try to be in communication with them.
When we first opened, we reached out to a lot of the local clinics in the area who we knew accepted Medicaid. We took them our flyers, told them we're open. We have no wait list for Medicaid patients. We're accepting them. And I think they definitely have been utilizing that resource. We've seen several from Salud, several from there's a few other specific Medicaid clinics here in the Aurora area that have been really, Himalayan Family Care, I think, is one as well, and Clinica, that they've utilized our referral system.
And I think the more that we can spread the word and help you in that, we definitely will. I think after this meeting, we can share the flyer from the dermatology clinic. The Center on Colfax has received flyers just to inform the LGBTQ community that utilizes services with them. And so I think that the more that we can get the word out with, referring providers and patients themselves, it is helpful. So we can definitely share that flyer with this group.
And I just want to add, and I don't know how many people it's getting out, but the Anschutz Medical Campus now has an LGBT resource hub that'll kick off on February 25th. And so if you were interested, I could connect you with their communications coordinator, who's kind of talking to all of the big players. So like the Trans Inclusive Center, the School of Medicine, Denver Health, and the city of Aurora is actually sponsoring that kickoff event. So I would love to, because we are very focused on the city, like Aurora needs in the LGBT community, as well as provider training for campus. And that covers children's, UC Health, like all of those people are part of the committees that have been formed. We had 130 people show up to be on our advisory committee that we thought was going to be 12 people. So now there's 6 advisory committees and there's very active, they have peer mentors And I'd love to connect you with Stephen because he's doing some good work.
Yeah, they might know about us. We've been in contact with Dr. Koutsanis and kind of everybody linked to the surgical area of the transgender community or the transgender services at the university. And he's been a huge champion as well, kind of like sending out lots and lots of emails with lots of people attached and letting them know about our services. So they may or may not know, but yes, we'd love to be in touch with them.
Yeah, and that's like the the Integrative Care Center is one little piece of the university, but the entire campus, there's a bunch of stuff going on with, that's what the hub is going to do. It's under the Vice Chancellor of Diversity, Equity, Inclusion, and Community Engagement. It's meant to be for the, like as a centralized place for people to learn. So I'll send some information.
Yeah, that'd be great. Would you mind just sharing that with the whole group so we could learn a little bit more about that?
Yeah, and we don't have a website yet. They're building that, but I'll send you what I can put together. And I'll give you the Stephen's name. You can always call him and talk to him about it.
Thanks, Dionysia and Kelly and Taylor. This is such a wonderful, refreshing discussion because dermatology, skincare, it is so neglected. And frankly, I don't know any dermatologists out there that will accept Medicaid without a cap. Maybe one or two, but it's such an important area. So as we get the word out, I also with the various other dermatology clinics, they do want to help people. They do want to heal, but because of certain restrictions, they can't take Medicaid people. So we need to make sure they know that you're out there. You're not out there as a competitor. You're out there to take the folks that they simply can't see. So certainly we do want to promote that. And then what's refreshing to hear is that you'll help the self-pay people and even try to find coupons for them. That is so wonderful to hear. I just, it's such a delightful conversation, Kelly and Taylor, and we just love that you're presenting to us. And now it's part of all of our job here, of all our participants here, is to get the word out and to everyone, including primary care folks who maybe perhaps, as Heather had mentioned, aren't doing what they should be doing on skincare, but if they do find a condition, what to do. That kind of brings up EConsults. Do you guys work with that with primary care? Primary care docs might call in and say, got this condition, what do you think?
I don't think our Epic here supports e-consult visits. We don't have I'm not sure, Dr. High, if you know, but I don't think we've ever been able to do them at our site. But we did reach out. We spoke to somebody when we first opened and they asked the same thing, and we were unable to accommodate that, but we had at that point same week availability, and most of the time we still do now. And so we just asked that they send them like as a referral, and we could probably see them very quickly. And as to your point about other dermatology clinics in the area, I do know several of them are aware of us. I had one patient who had insurance, lost his insurance, was on Medicaid, was being seen by advanced dermatology, was no longer able to be seen there, and they referred him to our clinic. And he was like, I'm so happy that like now I have this service. And so I think there are some out there who are aware that we accept Medicaid patients.
I'm not positive, but we could ask Dr. High if the e-consults can go to from any site to the university. I know they do e-consults. I think it's only internal though, but we could let you know about that later.
Yeah, that's a really good question. I know the main campus derm clinic is using e-consults because we definitely see the data showing, I think there was 300 and some last year. But yeah, specific to the new derm clinic, I'm not sure. Yeah, Dr. High might have more information on that.
Yeah, it's a restricted service right now.
So that might be something we look at, further down the road as e-consults start to expand into other areas.
It took a long time to go. At first, it was just family medicine and internal medicine. Now Salud can do it. It'll be a while before the financial details and HIPAA approved transmission methods and all those things would have to be worked out before it would be rolled out to just any person in any provider interested or anything like that. It's just all a staged type process. So it'll be a while before that that's available. But there is great availability now at Aurora, which is fantastic.
Yeah. And again, we're really happy to take any consultations and any referrals. And for a lot of patients who may have any barriers to getting here, at least we can start them with a telehealth visit if they're really having a difficult time coming in. There are some things that we really do need to see in person, but we can certainly at least get the conversation started and sort of plug the patient into the clinic and get their information and sort of facilitate things that way.
The other benefit we've seen too is there are some patients who, like you mentioned, have waited so long because they didn't have this service, and their skin condition is kind of more than what we can take on here in this clinic. But the benefit of us being here and being seen is that then we can at least like start the conversation. We can see them, get a note in, take photos, and then send an urgent referral to the main campus, and then they're able to be seen much faster than if they were just sent as a referral to the main campus and put on the wait list. So there is, even if we're not able to manage every single skin condition here, we're able to at least like open the door for them and get them where they need to go.
All right, do we have any other questions for our speakers? This was, as Rich said, a very refreshing conversation. You know, we have to really find opportunities to find solutions for access to specialty care, and the fact that we have this clinic in our community is wonderful. So we will definitely work to champion getting the word out and ensuring that individuals in the community know how to find you.
Great.
Thank you.
Thank you.
Wonderful job.
Appreciate it. It was nice to meet everyone.
Yes, thank you. So I think up next, we are going to get an update on the specialty care survey. And Dionysia, I'm gonna kick it off to you.
There were, Dionysia, there was also a couple of, you don't have to do it like right this second, obviously, a request for more information about the open house. I think that was
yeah, and so just, you know, that LGBTQ hub at Anschutz, I put it in the chat.
Okay.
Stephen is a public health student that's acting as kind of the communications coordinator for that project. I'm the project manager, but that just is, I'm just kind of, there's a consultant that's building out this hub, and they're kicking it off February 25th. So I might be able to, I can answer some questions, but Stephen really is the person you want to reach out to, because they will be able to.
And we can try to do that at the Alliance, and then we'll include it in meeting follow-up when we have more information.
Yeah, that would be great. And yes, because like the city of Aurora ended up giving us some money to sponsor that first kickoff event. They're planning a conference in October, and they have a bunch of events and book clubs. But we were very intentional, and I say we, meaning the Office of Diversity, Equity, Inclusion, and Community Engagement, are intentional about including Aurora and how that hub is being built and how we're thinking about it. And so even how we invited people, I sent it out through like the AACS, like community members were invited to the table. So like Josh, there's a couple of people from Aurora on committees. So
cool, thanks.
As much as I can continue to do that, and Regina thinks that way too. So I think it'll continue even past my tenure as the project manager. Okay, so the Specialty Care Access Project, Eugene's actually going to present. And I will just say, and this is where I am working hard to get my practice innovation team onto this call. So some of you have heard Allison Gottsman's name mentioned in different pockets. She is now on this project, which is a big deal. If I just know that that's going to make some of these things connect, because I didn't even know what specialty care access when I started this project, but all of the people that I work with, they're talking about all of that EConsults with Stride and Epic, and they know all the details of that. And so getting someone from my practice innovation team on this call is going to help us kind of start to and again, I'm going to continue to push for us to come up with solutions for Aurora. But I think that Aurora could be a good place for, as they start to think about bigger solutions, that they start small, small in Aurora. And that's what I'll continue to push for. So I'm going to kick it over to Eugene. He's going to summarize some of the data we're seeing so far.
Yeah. So hey everyone, I'm Eugene. I'm one of the second-year medical students working on this project. And so kind of just a quick update as in terms of where we're at right now. We have completed the survey and are currently in the process of sending it out to the database of all of the primary care clinics that we have so far. And I think right now we have around 60-ish clinics that we are sending the survey out to, and we're beginning to get some responses from people. Most of the responses we're getting are from Stride and Dawn, which is kind of what we'd expect at first, because those are kind of the closest ties that we have coming from the CU School of Medicine, Department of Family Medicine. And so far we've gotten 18 responses, and with the preliminary data that we're seeing so far in terms of the areas that have the greatest need, we're seeing that orthopedics, specifically operative care within the field of orthopedics, has the greatest need for both our uninsured and Medicaid patients. And in terms of the specialties that have kind of the best services for both the uninsured and Medicaid patients, we're seeing that the field of cardiology has posed the least barriers for our primary care providers in terms of getting patients into the clinics within Aurora. So we're still very much in the early processes of just getting more data in, and we're expecting to hopefully get more responses is really where we're at right now. And so hopefully in the next few months, we'll get more and more responses, be able to have a more robust data set, and can present that to you guys.
And I'll just add just real quick, a couple things. One, so bringing Allison on, she's able to really she either has relationships or is willing to kind of knock on doors, but because of COVID right now, she's not able to do as, there's nothing about her that's aggressive, but she's not able to be aggressive with getting this survey, right? Because the practices are overloaded, COVID activities. The second thing I'll say is that what Eugene just summarized is we made this survey in a way that it has a short answers that you could do in a quick way. And then we said, hey, are you willing to kind of dive deeper with us? And so what Eugene is summarizing is we just ask very straightforward, what are your top 3 problem, like what's the highest issue ones? And we actually asked for 5. And then what are the ones that are like relatively, and I can't remember how we worded it, but the bottom 3, meaning like, I don't worry about these when I need referrals for these. And so that's that piece. But then we did ask people if they wanted to go deeper. And it was kind of based off of a manuscript we saw, but then a lot of just kind of brainstorming and thinking about what would be most useful information. And the majority of people said yes to that piece. And we just have not done anything with that data yet. And it's a little too early to start to draw any conclusions, but I am excited to see that almost everybody that took the survey said yes to answering more deeper questions.
So it would help me to know a couple things, what your final list was. If you'd like Colorado Access to help, we've got 2 provider-facing teams, and we're working directly with those practices in Aurora. So we can certainly, if we know what the survey looks like, if we understand who it's coming from, all those things, and we can alert our providers to that. What will make a difference for them is to know to what end. So if they're answering those questions for you because you're one of many who have asked them this, they need to know to what end. what's going to make the difference. So I'll tell you that where I've been spending my time is letting my teams know about the dermatology clinic. That's already, I'm hearing back from my colleagues, they're getting that out there because that's a huge need. So when we've got something like that we can say, yeah, you're being asked this, but here's the end that's going to happen, then you're going to get some traction.
Okay. And I think I was just looking at the survey. I think we kind of summarized that in the survey. But I can get you some more blurbs, but I think as this group, the goal of this survey is to kind of get in, and I always use this as an example. At that first meeting, Molly said, I don't know what to do with this big problem.
Yeah, I am. Can you give me 2 minutes? I'm getting out this other.
Oh no, you don't have to. Oh, sorry. I thought you were talking to me.
I'm sorry. I hit the wrong button.
They presented this big, huge problem for the state, and it wasn't really teased out even regionally. And then Molly at that meeting said, I don't know how to deal with that big problem, but I just can help one person at a time. And we're trying to do somewhere in between there. Trying to get, like, for example, if we show that or the orthopedic is the thing, then we would start to like figure out how to make a tangible way to address that, get the right people at the table, figure out what, like, for example, the whole thing with EConsults, the university has like a EConsult team, and this is where I'm going to sound really ignorant because I don't know all the details, but my team does. But that's where we can start to, like, if we say like, hey, this is the problem right here, and start to like hone in and tackle that problem for that specific area is my vision for how this survey will be used. And then as far as the list of practices, Joe, I had a student research assistant last semester. And what he did is he called all the practices that we had on that big list, which I'm pretty sure you've seen before, but Eugene or Clay can share it with you again. And there were several on our list that didn't even take Medicaid. So they were eliminated from the big list that we started with. But we certainly, Eugene, can you work with Joe to nail down clinics that she can
certainly.
help with? Yeah. And we can.
I think it's going to be really interesting with the more data and the more information we have, because we have our anecdotal data where it's claims that are paid, but I don't think anyone's ever done what you're doing. I mean, I think that we all have anecdotal stories of here's what I've ran into with this patient and here's what I hear from care managers, but I don't think anyone's done the broader scope approach of reaching out to all of these providers in the community. So I just appreciate that you guys are taking the time to do it, because I think it's going to create a lot of value and a lot of good work is going to come out of it. And I think we should align it with, in 2018, here's what we saw with HCPUF and the CU School of Medicine with these 3 areas. Is that still the case? Is that still something we're seeing where the data shows one thing, but do providers and patients experience something different? So I think that we're going to get a lot of good, rich information out of this, and it'll help our access to specialty care group kind of hone in on what we can do collectively to create better access. So if there's anything we can do in the meantime in terms of getting the word out, as Joe mentioned, if there's providers that Colorado Access interfaces with, or any of us within the work group that we can give some nudges to, we're happy to do that.
Yeah, and I think, and so Eugene can share that with you guys and see kind of tease it out more. But again, I think some of it is the COVID, like just kind of easing up on people right now. And I appreciate what you said, Heather, and that's the strategy here is if we were in a vacuum and it was just the Aurora Health Alliance, we would take this information and we would just kind of get in the weeds and like come up with a brochure or get different people connected, right? Because what I'm learning is the old school way of doing like e-consults and stuff. You just called your friend that was a specialist and they were willing to talk on the phone with you about it. And like Colorado Springs has a medical society that's managing their referrals so that everybody felt like they were neutral and fair. So there's been non-technical, non-big picture solutions to this kind of stuff. But until we kind of nail down exactly who where the little sticking points are, we can't really dig into that. But then separate from that, my team, the Practice Innovation Program, and I say my team, I'm a worker in that big team. You know, we have a UPL funded project that's working with the Salud Clinic, and Allison talks to people at HICPUP. Like, this is the part where I don't know all the big picture, but I know that these people understanding this context of Aurora could help us solve, you know, help us kind of push up things in other spaces that maybe, like, I certainly don't have access to, but that's kind of my strategy here, is both give us tangible ways to dig into the work and also to push up where people can make bigger changes.
I just want to note that it's 11:03, so maybe Molly's comment, and then we were going to ask a question of the group, Mandy, and I don't know if we want to do that via email, just so we can respect everyone's time. But Molly, why don't you go ahead with your final comment?
I'm not the medical, sorry, I've got volumes going on here, but anyway, I'm not the medical expert, but is it because cardiology is life-threatening and that other one, ortho, you can live with and suffer? And if that's the case, sorry, I'm gonna hit a button. Okay, if that's the case, what else is life-threatening versus can live with it? And we can make assumptions?
That's certainly, I would like to look at the data more and see if that's what it is. But yeah, I can't answer that question.
Yeah, that is certainly one of the questions that we're asking feedback on in terms of the secondary survey, where we're asking these providers, okay, like, what is the greatest barrier for you in terms of accessing these specialties? And also, like, what has made these other specialties easier to access compared to others? So we'll hopefully tease that out more, and hopefully more of a free response kind of answer in the survey.
Well, thank you for that detailed update. It's important work. And again, I think it's going to help guide a lot of the things that we collectively do in the future. Well, seeing that we're a little past time, I just wanted to thank everybody for your participation today. I think we learned a lot, and we'll have ongoing conversations on just how we can further partner around access to specialty care. And Mandy, I know that we were going to maybe ask the group some questions just kind of about strategic vision for the work group moving forward. And so some of that we might be able to take care of via email, if not at our next meeting.
Yep, sounds good. And anyone, if you have any, ideas on things, you can always outreach the Aurora Health Alliance, and we're here to listen.
Thanks, everybody. Have a great day.